Hello, good evening, everyone. Today we will continue our Harrison-based series on pain, and we will start with our new topic that is chest discomfort. Now, chest discomfort is the most common cause by which patients usually present in our emergency and OPD. The most common symptom which we usually see in our day-to-day scenario is chest pain. Now, we will see that only 15 to 20% of patients presenting with chest pain actually have acute coronary syndrome. So majority of patients are not having acute coronary syndrome. Majority of patients, that is most common cause of chest pain is gastrointestinal. So before we go into chest pain, we should know how to triage the patient of chest pain. And there are three headings in them. First is we will divide in myocardial ischemia, another is other cardiopulmonary cause, other is non-cardiopulmonary cause, and then there are 2 to 6% of patients with chest discomfort due to ischemic causes, which are usually missed and which are later present with myocardial infarction. And our whole goal of study of this topic is to not to miss that these 2 to 6% of patients, which we are usually missing in our emergency and casualty or OPD. So in this diagram, we can clearly see that gastrointestinal roughly around 42% of patients of chest pain, and which is second most common is ischemic heart disease. So, and third is chest wall syndrome, fourth is pericarditis, and fifth is pleuritis. So, what we have seen that most common cause of chest pain is GIT, not ischemic heart disease, and ischemic heart disease comes in at second number. So, how to remember the cause of chest pain? I will tell you. Just start with your skin. This is your chest. We will start with skin. If there is some lesion on skin, like in herpes zoster, you can get pain. If there is some burn on skin, you can get chest pain. Below skin, what is below skin is your muscle or fat. So any myositis at that area, you can get pain. Below muscle, what is there is bone. So any trauma to bone, you can get chest pain. When we go below our rib cage system, what we get heart. So any condition which lead to myocarditis, which will lead to pericarditis, they can lead to chest pain. When we go below heart, what is there? It is trachea and esophagus. In esophagus, which kind of pains we can get? We can get peptic ulcer pain, we can get GRD type of pain. So this is how we can remember the pain of chest pain. So we will start with causes. Now we will divide our causes in two headings. First is cardiopulmonary cause. In cardiopulmonary, we will first see cardiac cause. Cardiac cause can be myocardial ischemia, or it can be pericarditis. In myocardial ischemia, you can have stable angina. You can also have unstable angina. You can have non-ST elevation MI. You can have ST elevation MI. So these are cardiac cause under cardiopulmonary. Second is your vascular cause. In vascular, the most common can be acute aortic syndrome. Okay, my friends. Now, after acute aortic syndrome is pulmonary embolism. Okay. Third one is pulmonary artery hypertension. Okay. Now we have seen cardiac, we have seen vascular. Now we'll come to pulmonary component. In pulmonary component, we can have pneumonia, we can have pneumothorax. Okay. We can have pleuritis kind of pain. Okay. Now we will come to non-cardiopulmonary cause. And we know the most common cause is GI. So gastrointestinal. It can be divided in GERD. Okay. Then esophageal spasm. Okay. Then peptic ulcer disease. Okay. So what we have seen in GI, it is GERD, esophageal spasm, peptic ulcer disease. And last is gallbladder disease. After GI, we will come into neuromuscular. In neuromuscular, it is trauma, then it is costochondritis. Okay. And also herpes zoster. And last but not the least is your psychological causes like anxiety and depression. So we will revise our list. We, we start with first is cardiopulmonary. Pulmonary. In cardiopulmonary heading, it is cardiac, vascular, and pulmonary. In cardiac, it is myocardial ischemia. Under myocardial ischemia, it is stable angina, unstable angina, non-ST elevation MI, and ST elevation MI. Then it's pericarditis. Under vascular, it is acute aortic syndrome, or it is pulmonary embolism, or it is pulmonary artery hypertension. Under pulmonary, you are having pneumonia, pneumothorax, and pleuritis. Under non-cardiopulmonary causes, you are having GI causes in which there is GERD, then esophageal spasm, then peptic ulcer disease, then gallbladder disease. In neuromuscular, you are having trauma, costochondritis, and herpes zoster. And last but not the least is your psychological cause. Now we will come to cardiac cause. So in this table of Harrison, you can see they have clearly mentioned in cardiac, first is myocardial ischemia and other is pericarditis. Under myocardial ischemia, they have mentioned stable angina, unstable angina, and myocardial infarction. So we will see what is stable angina and unstable angina and ST elevation amine further. First, we see what is the quality of pain. So it is a pressure, a tightness, squeezing, heaviness. Someone has put you something on your chest, like squeezing your chest. Okay. Location is retrosternal type radiation, and this pain radiates your neck, jaw, shoulder, arms, and your epigastric area. What are the associated features you can have? You can have gallop rhythm. Gallop rhythm is for because of if due to MI patient goes in failure. You can have mitral regurgitation. It is mechanical complication of MI. You can get bilateral collapse because MI can lead to heart failure and heart failure can lead to pulmonary edema. So on auscultation, you can get bilateral collapse or this. So we will see myocardial issue. Now we all know that heart main tissue is myocardial. Now suppose this is your myocardium and These are your small coronary arteries which are supplying. Okay. Now, what coronary artery brings to myocardium? Blood. And with blood, what comes? With blood comes oxygen, nutrients. Now, suppose if there is any blockage in this area of coronary artery, what will happen? Blood will not go to this myocardial area. So, oxygen will not reach. So, myocardial ischemia is all about mismanagement in your oxygen supply. So, how can we say? We can say that there is mismatch of oxygen supply. That is decrease in oxygen supply and increase in oxygen requirement. Okay. Now, what all are conditions which lead to decrease in oxygen supply? We will see. First is your increasing heart rate. Now, how increasing heart rate will lead to less oxygen supply? When heart rate increases, your diastolic period decreases because majority of cardiac cycle comprised of your diastolic period. And in diastolic period is the important period because in that only period the heart fills. So if your heart rate increase, your diastolic period will decrease, and diastolic period will decrease, so blood reaching to heart will decrease. And if blood reaching to heart will decrease, then obviously your oxygen supply will decrease. Okay. After heart rate, what is there is an increase in ventricular wall stress. Now suppose what do you mean by increase in ventricular wall stress? Suppose this is your myocardium and your suppose your myocardium size increases due to any condition, maybe because of hypertension, your left ventricle has gone in hypertrophy, LVH is there, or anything which has led to increase in myocardium size. Now, if myocardium size will increase, these coronary arteries are here supplying here. Now, if myocardium is thick and big, if it will contract, it will squeeze coronary artery completely. So blood will not go properly. So that's why increase in ventricular stress will lead to decrease in oxygen supply. Other is increase in contractility. That I mentioned already. If contractility increase, also same will happen because your myocardium will contract vigorously. If it contracts vigorously, then your coronary artery will shrink. And if coronary artery will shrink, blood flow will automatically will decrease. Now we come to factors which lead to increase in oxygen requirement. So, so all these factors leads to increase in oxygen requirement. Now we will study factors leading to decrease in oxygen supply. Now, when there is decrease in coronary blood flow, and what is the most common reason which lead to decrease in coronary blood flow is any atherosclerotic plaque you get. Okay, so increase in oxygen requirement, decrease in oxygen supply, mismatch between them lead to myocardial ischemia. Now we will see what is stable angina, what is unstable angina, non-aspiration and aspiration. Now we come to stable angina. Now remember, in heart, pain will only occur when your coronary artery blockage is greater than 70%. So if blockage is less than 70%, you will not get myocardial ischemia type of pain. Now, when we are coming to stable angina, suppose this is your coronary artery, okay, and this is the atherosclerotic plaque, okay, and there is a characteristic feature of this plaque which is happening in stable angina is that this plaque is fixed. and it gradually increases. And it gradually increases. Okay. Now, when this plaque increases and it blocks coronary artery by greater than 70%, then pain will start. And in stable angina, pain is at exertion or at activity. Okay. At rest, pain decreases. Now, why this is happening? Because 70% blockage is there. So, your blood can go. Okay. But when you are doing any kind of exercise, the requirement of blood increases, but space is limited. So that's why when you are doing any kind of exercise, any kind of activity, you will get pain. Okay. But this plaque gradually increases and it is fixed. Now, what is the characteristic of stable angina? Is that this pain usually usually lasts for less than 20 minutes. And this pain subsides, pain subsides on giving NTG. So whenever patient comes in your casualty and emergency and patient comes with stable angina pain, you give him sublingual NTG tablet. Automatically within 1 to 5 minutes, the pain of patient will subside. And that is the characteristic feature of stable angina. Okay. Now we will see what is unstable angina. Okay. So actually there is a term known as unstable ischemic heart disease. Now you will ask, sir, what is unstable in this? Actually, plaque is there is also in is this condition also. But here, due to some factor, plaque is vulnerable. And when plaque is vulnerable, it it any time can it can dislodge. And if this vulnerable plaque will dislodge, it will lead to a cascade process with thrombosis. And this thrombosis will lead to pain. So in unstable angina, there is vulnerable plaque. Okay. This vulnerable plaque leads to thrombosis. Okay. Now, in unstable angina, sorry, unstable ischemic heart disease, it can be divided into two things. First, if patient comes with unstable ischemic heart disease due to vulnerable plaque, you have done ECG. If in ECG you get ST elevation, okay, and biomarkers positive, then it is STEMI. But if in ECG there is no ST elevation, then we will move on to biomarkers. If biomarkers are negative, then it is unstable angina, and if it is positive, then it is non-ST elevation ML. Okay. And what are the characteristics of unstable ischemic heart disease? It lasts greater than 20 minutes, and pain doesn't subsides on giving NTG tablets, and this pain is in on rest also. So if patient comes to you in emergency and that pain is lasting more than 20 minutes, pain is occurring at rest, then you must order an ECG because it is an unstable ischemic heart disease. If you get ECG done, then on if ECG you are finding ST elevation, then 90% chance that it is ST elevation MI. You can also do biomarkers like cardiac trop T and trop I. But if in EC there is no ST elevation, then move on to biomarkers. If biomarkers are positive, then it is non-ST elevation MI, and if biomarkers are negative, then it is unstable angina. So you can see in this diagram. Now I will tell you one more thing, that this unstable angina plus non-ST elevation MI plus ST elevation MI, all these combined are known as ACS. And what ACS is? It is acute coronary syndrome. Now you will ask me one thing, that sir, why unstable ischemic heart disease there is ST elevation in STEMI and why there is no ST elevation in STEMI in US? So reason is that ST elevation occurs when there is complete blockage. So in unstable angina and non-ST elevation MI, occlusion is there, but this occlusion is partial occlusion. Okay. But in STEMI, where ST elevation is there, then their occlusion is complete occlusion. We will see this in diagram. See this diagram. Now see this diagram. Here, plaque is vulnerable. That is the most important thing. And vulnerable plaque, if it occluded the artery partially, then it is unstable angina or non-ST elevation MI. And if this plaque occludes completely, it leads to ST elevation, and that is ST elevation MI. Okay. Now, now you are seeing this. You are seeing this image, na? So, patient clinically present you with acute coronary syndrome, acute ACS. Now, patient is having pain like is myocardial ischemic kind of pain. That is tightening, squeezing pain. That someone is like sitting, na, and squeezing your chest like anything. So, you give him nitrate. Patient doesn't pain is not releasing on nitrate. You are suspecting then unstable ischemic heart disease. Then you order a ECG. If ordering ECG, you are getting ST elevation, then it is ST elevation MI. If ECG is normal, then you consider some other heart disease. And if you are finding ST depression or T wave inversion, then what you order? You order biomarkers. If biomarkers are elevated, then it is ST elevation MI. And if not elevated, then it is unstable angina. Okay. Now, now, now there is a term known as acute coronary syndrome. Okay. Now, in acute coronary syndrome, patient is having? Patient is having myocardial infarction. Okay. Now, how do you define acute MI? Okay. So we will see what is the definition of acute MI. When we say patient is having myocardial infarction, acute MI, or he is in AC static. So when there is a myocardial injury, okay, myocardial injury is mandatory. So patient having myocardial injury. So when if this is your myocardial tissue and if it is damaged, what it will release? It will release some chemicals. And what are these chemicals? These chemicals are your biomarkers. And your biomarkers like TROP-T, TROP-I, they will be elevated. Okay. So myocardial injury. And there should be acute rise and fall of TROP-T or I levels. So because there are many other reasons also in which TROP-T, TROP-I increases. So what new guidelines say that if patient is having myocardial injury, TROP-T or TROP-I should be increased but there should be acute rise and fall of tropy and tropi should be there. And because you here you are seeing subsequent values of tropy and tropi. Suppose you are seeing tropy and tropi at 1 hour, then you are seeing at 2 hour, then you are seeing 3 hour, then you are seeing 4 hour. So suppose there are four values. One is 1 hour, other is at 2 hour, other is at 3 hour. So you have to see acute rise and fall of tropy and tropi level. And one value of your tropi and trop T should be above 99 percentile. Okay, so there should be acute rise and fall of tropi, and one of the value of tropi should be above 99 percentile. Then you will say that this is a myocardial injury. Plus clinical evidence of myocardial ischemia. So what is clinical evidence of myocardial ischemia? So in new guidelines, there are five evidence which are suggested for myocardial ischemia. From these five evidence, only one, if one is positive, then you will say it is MI. So one out of any five. Now, what are these evidence? We will see in further slide. Okay. So acute MI is defined as myocardial injury with acute rise and fall of trop I and trop T levels with one of the values above 99 percentile plus clinical evidence of myocardial ischemia in which there are five factors. At least one should be positive. Now, here we are seeing a diagram of cardiac troponin in various heart diseases. First is myocarditis, then is CHF, then is myocardial infarction. Now, you can clearly see myocardial infarction that one value is above 99. Criteria satisfied. Okay. Other thing, you are seeing that one value is above 99 and there is acute rise and then there is acute fall. So this is MI. Other thing, here you are seeing congestive heart failure patient where tropi is elevated, but there is no acute rise or acute fall. That is CHF. Other, here you are seeing myocarditis. Here, there is acute rise and acute fall. Okay. But here you're seeing that none of the values above 99 percentile. That's why we haven't labeled this as acute MI. But due to acute rise and fall of biomarker, we are labeling it myocarditis because there is some injury in myocardium. Okay. Now we will see what are the clinical evidence. Okay. Now first is symptoms. What is symptom? You mean by symptom that am I patient having symptoms like tightening, squeezing kind of pain? These are all are symptoms having precipitation, nausea, vomiting, dyspnea. If these kind of symptoms are there. Second, we come to new onset ECG changes. It means just like acute rise in tropy and tropi, there should be acute changes in ECG, which is known as dynamic pattern. So you have to see subsequent ECG, and according to that, you will see new onset ECG changes. Third is development of Q waves. Okay. Fourth, imaging evidence. Now, what kind of imaging evidence? Like you can do echo, and what you will see in echo. Now, suppose This is your heart, and in this portion of your heart has been infarcted. Okay. Now, when this portion of heart will be infarcted, when your heart will contract, this infarct part will not move. This infarct part will not move. Okay. When the infarct part will not move, other parts will move. So only a restricted part of heart is not moving. So we will say a regional, a regional part of heart is not moving. Okay. And if something is not moving, we'll say motion. Okay. So there is a regional motion abnormality, which is known as RWLA. So on echo, you will see a regional wall motion abnormality because a particular part of heart that is infarcted of left ventricular area, that part will not move, and that one part in echo will appear as a regional wall motion abnormality. Fifth is angio evidence. If you are doing PCA and that in that you are finding any block, that is the angio evidence. Okay. Now we will see what all are other conditions in which trophy can be increased. Other condition in which trophy can be increased. That is your sepsis, that is your CKD, that is your pulmonary embolism patient, then it can be your myocarditis, then can be your Takotsubo cardiomyopathy. So what we are seeing here that there are two condition of heart, that is myocarditis and Takotsubo cardiomyopathy. In this also condition, that trophy and trophy can also be increased. Other, when you are giving shock to patient, a DC shock, then also can be trophy and trophy be increased. Okay. Now there is an important sign in MI, that is Levine sign, in which the patient is clenching his fist held over the chest to describe the tightening or pressure felt during a heart attack. Now, here we can see that this MI pain is dull and diffuse kind, and it's like your heart because you can't localize the pain, so it is dull and diffuse, and is presenting pressure, tightness, and squeezing. Now we come to classification of MI. So MI can be classified into five headings. First is type 1 MI, which is generally due to a plaque rupture. Okay. Second is your supply demand mismatch. Generally, your oxygen mismatch is there. Okay. Third is sudden cardiac death. Okay. And fourth and fifth are procedure related MI. Okay. And in type 1 and type 2 MI, what we have found that type 1 MI is more dangerous than type 2 MI. Type 1 MI is more severe than type 2 MI. And why? Because what is happening type 1? In type 1, if this is myocardium, and these are your coronary arteries. And suppose there is some plaque. So blood will no go. So there is decrease in oxygen, decrease in nutrient supply, and increase in metabolic waste. Okay, but when we see type 2 MI, in type 2 MI, there is only decrease in oxygen. The other factor which is in type 1, that is decrease in nutrient supply and increase in metabolic waste, is not in type 2 MI. That's why type 2 MI is not that much severe as compared to type 1 MI. And in type 2 MI, you don't have to do any procedure like PCI and CBD. Okay, now we will come to likelihoods of MI. Now, in this trial, because we know that cardiac pain radiates either to jaw, either to left hand or to right hand. So this is a trial done in which which tells us about the likelihood of MI pain. In this, you can see that most likelihood was of radiation to right arm or shoulder carry maximum likelihood. Then comes to radiation to both arms. Then comes associated with exertion. And in fourth position is your radiation to left arm. Generally, what our old thinking was that when pain related to left arm is the most increasing have increased likelihood of chances. But no, radiation to right arm or shoulder in recent trial has been listed at the top first position. Now, as this MI is a very much serious situation and serious kind of thing, so in new guidelines there is score design that is known as Hertz score, which is given by American Heart Association of Cardiology. Now, what is this Hertz score? So, Hertz score in Hertz score, H stands for history, E stands for ECG, A stands for age, R stands for risk factors. Okay, so this Hertz score itself is a mnemonic. And if Hertz score is low risk, is when it is between 0 to 3, and it is high risk if it is greater than 4. Okay, so this is a score we commonly use in our emergency setting, that is Hertz score. Easily you have to remember, I have tell you that H stands for history, E stands for ECG, A stands for age, and R stands for risk factors. Okay. Now suppose patients come you with acute chest pain, which you are thinking like that this is a MI kind of pain. You order a ECG, and if in ECG you are getting ST elevation, ST elevation increase, you predict that is a ST elevation MI, and you will work according to that ST elevation MI. If suppose ECG comes out to be a normal, then what we will do? If ECG comes out to be normal, it can be divided into two things. Either it is a non-ischemic or it is ischemic type of pain. Okay. If it is ischemic type of pain, you will order troponin levels. And if any value of troponin is greater than 99%, you will consult with cardiology. If it is less than 99%, you will observe it in patient in emergency for 3 to 4 hours. If pain is non-ischemic and if patient is a known case of CAD, means patient is prior having any episode of MI, then you will also order initial troponin levels. Now, if patient is non-ischemic and is not a case of known CAD, then you will do a Hertz score. If Hertz score is between 0 to 3, then you will do serial troponins. And if serial troponins come less than 99%, you will discharge the patient. If it comes greater than 99%, you will send it to cardiology. And if serial troponins come greater than 4, and if in any of greater than 4, your value is 99%, then you will again send your patient to cardiology. Okay. Now there is another term that is known as angina equivalents. No, what is angina equivalent? So these things are seen common in elderly patient, female patient, and diabetic patient. Because diabetic patient, you are having autonomic neuropathy, so you can't know the pain if pain is happening or not. So in these, shortness of breath, perspiration, diaphoresis, if syncope, any GI kind of symptoms like epigastric pain, nausea, vomiting, fatigue, or confusion. So we shouldn't miss these kinds of symptoms. These are angina equivalents, and we should remember, especially when patients like diabetic or elderly patient greater than 70 or 80. Now we will come to other heading of cardiac, that is pericarditis. It is quality pleuratic type, sharp. It is retrosternal towards cardiac apex, and it may radiate to left shoulder, and especially in left shoulder trapezius. It may be relieved by sitting up and leaning forward, and pericardial friction rub can be present here. So, first we will see why pericarditis have a pleuritic type of pain. So, suppose this is your heart, okay, and this is your outer layer of pericardium. Due to pericarditis, suppose this is pericarditis, there is some fibrinous layer in between them. Due to this material, they are getting rub against each other. Okay, now these are lungs, okay, which are enclosing heart. Okay. Now we know in inspiration, lung will expand. If lung will expand, then heart will always shrunk, or heart size will get small. If heart size will get small, then these two pericardium layer will get more time to get rubbed with each other. So that's why in inspiration, your pericardial rub pain increases. And opposite to that happen in expiration. In expiration, your lung volume, lung size decreases. So heart has enough space to expand. So pericardium layer doesn't get enough time to rub with each other. That's why on expiration pain decreases and on inspiration pain increases. Now, when any pain which increase on inspiration and decrease on expiration, this thing generally happen with pain of respiratory disease. So the pericardium pain is like respiratory disease pain. It increases on inspiration, decrease on expiration. That's why we have given him the name of pleuritic type of pain. Okay. Now, other thing is that we are seeing here is that this pain may be relieved by sitting up and leaning forward. Okay. Now, what we see that suppose this is your heart. Okay. Now, when you are in supine position, what will happen? Because your heart is filled with blood. Okay. This blood will exert some gravity on this heart. And due to this gravity on heart, when you are in supine position, this pericardium layer will come in close proximity. And if they come in close proximity, they will again rub with each other. So in supine position, the pain of pericardium increases. And in leaning forward, it decreases. Okay. Opposite to that, there is something known as paradox in pericarditis. What is paradox? The pain decreases on leaning forward, but the pericardial rub which you get in pericarditis, it increases on leaning forward. Okay, I think I've got this. Now, generally, because pericarditis pain mimics pleuritic type of pain, so you have to differentiate pericardial rub from pleural rub. How can you distinguish between these two? Now, pericardial rub pain persists with pericardial effusion, but pleural rub pain goes with pleural effusion. So, when you are having pleuritis and you develop pleural effusion, the pleural rub will go away. But pericardial rub, when this pericardial effusion, it will still persist. Other thing is that when you stop breathing, your pericardial rub will persist. But when you stop breathing, your pleural rub pain will go. Okay. So you know how to differentiate pericardial rub and pleural rub. Pericardial rub pain persists with pericardial effusion, but pleural rub pain goes away with pleural effusion. Pericardial rub always happening when you stop breathing also, but pleural rub pain or pleural rub goes away when you stop breathing. Now we will come to vascular causes. In vascular, we are having three causes. One is acute aortic syndrome, one is pulmonary embolism, another is pulmonary artery hypertension. So first we'll see acute aortic syndrome. Now, this kind of pain has a sudden onset. Okay. And this pain is like tearing, ripping, or knife-like pain. That someone has put your stab you with knife on your chest. This pain is anteriorly present on chest, which often radiate to back, and that is between shoulder blades. Okay. It is associated with hypertension, any connective tissue disorder, murmurs like aortic insufficiency like AR murmur, and there is loss of peripheral pulses. So, in aortic dissection, there is tear in aortic intima, okay, which resulting in separation of media and leading to creation of a false lumen. Now, aortic dissection can involve ascending aorta or descending aorta. Okay, if it involves ascending aorta, then pain radiate to on front of chest. And if it is non descending aorta, then pain radiate to back. Okay, but what we have found that aortic dissection generally begins in ascending aorta, then goes on to descending aorta. That is why pain happens first in front of chest and then go back to back. Okay. Now we will come to other vascular cause, that is your pulmonary embolism. Okay. It is also having a sudden kind of onset. Okay. As it relates with respiratory system, it is in a pleuritic type of pain, which may manifestation with heaviness if there is a massive pulmonary embolism. Why with heaviness? Because massive pulmonary embolism behaves like MI. That's why in massive pulmonary embolism you are like heaviness, which often is present laterally and on the side of embolism, which present to with us with dyspnea, tachypnea, tachycardia, and hypotension. Okay, now what we see that pulmonary embolism, it can be small emboli or it can be a large emboli. If it is a small emboli, okay, then it pain will be a lateral and pleuritic type of pain. And how it will present? It will present like a pulmonary infarction. Okay. Now, suppose if it is large emboli, large emboli can dislodge into pulmonary artery. Okay. Now, if this is your heart and that is your right ventricle, and this is your pulmonary artery leaving from your right ventricle. If this large emboli dislodges in pulmonary artery, RV will found difficult to pass on blood to pulmonary artery. And what will it will lead to? It will lead to increased right ventricular pressure, which will lead to increase in right ventricular hypertrophy. So this large MI can lead to right ventricular hypertrophy. That's how it can also mimic like MI kind of thing. In last, in vascular is pulmonary hypertension. It is variable and often it can be exertional also. It behaves like a pressure kind of pain, which is substernal, and dyspnea and signs of increased venous pressure can be present here. Okay. Now we will move on to pulmonary. In pulmonary, there are two. One is pneumonia, and other thing is your spontaneous pneumothorax. Okay. Pneumonia or pleuritis can be variable pain. As it is involving respiratory system, pain will be pleuritic. Okay. It is unilateral, means at site where pneumonia is there, and it is often localized to that area only. Patient present you with dyspnea, cough, fever, rales, and occasionally rub can be there. Okay. Now we will come to spontaneous pneumothorax. It can be of sudden onset. It can be also pleuritic. It can go to lateral side of pneumothorax, and it can present with dyspnea, decreased breath, and sounds on side of pneumothorax. Means at side where pneumothorax is there, breath sound there will be decreased. Now, pneumothorax can be primary or can be secondary. Secondary is due to any underlying lung disease. That can be your asthma or COPD. Primary is in males. smoker, and any patient of Marfan syndrome. And in pneumothorax, emergencies of tension pneumothorax. Okay. Now, after completing our cardiopulmonary section, we will come to our non-cardiopulmonary causes. And we know that non-cardiopulmonary pulmonary causes are the most common causes, and in that also GI causes are the most common. In GI, first is your esophageal reflux disease, that is GERD. Pain duration generally about 10 to 60 minutes. And the pain is like burning. There's some acid is coming in your mouth like that. It is substernal and epigastric. It worsens by postprandial meal recumbency and it is relieved by antacids. Okay. Other is your esophageal spasm, which lasts for 2 to 30 minutes, which is of pressure, tightness, burning kind. It is also retrosternal and it can closely mimic angina. So GRD and esophageal spasm are closely mimics of MI. But how can you distinguish that pain of GRD and esophageal spasm is the pinpoint because the sharp kind of pain. But MI pain is dull and diffuse. So there you found a Levine sign of kind of presentation, which patient comes with a hand with a fist kind of which he made on his chest. Third is your pepticles. It generally about 6 to 9 minutes after meals. It is also burning like of pain, epigastric and substernal, and is relieved with food or antacids. Okay. Now comes with gallbladder disease. How GB disease can happen? It can happen through any GB stone. Okay. Here you will find a clocky type of pain in right upper quadrant, sometimes reading to bell. It also may follow after meal. Okay. Now in non-cardiopulmonary, other section is your neuromuscular. In neuromuscular, first is your costochondritis. That is most common in neuromuscular region. It is variable. It is aching kind of pain. It is also sternal in nature, sometimes swollen, tender, warm over joint may be there. Matlab, suppose if if this point of constituent is there, then here will be some inflammation kind of thing there will be there. Redness, tenderness, warm. And on touching, on localizing it, pain can be reproduced. Because in MI, if you touch, pain can't be there. But in costochondritis kind of thing, if you touch, you can reproduce the pain. So that's how you can differentiate between costochondritis and MI. Other is a cervical disease, which is variable. Again, it is aching, may include numbness. It may relate to your arm and shoulders, and it may be exacerbated by your movement of neck. That's why generally ortho physician prescribe you rest. Other is your any trauma to chest or any kind of strain over chest. Now, these kinds of pain are usually constant because they will remain until there is a trauma kind of thing. There is. It is aching kind. It is localized to the area of trauma. It can't radiate and it reproduced by the movement or palpation. What I've said, if any cosmolitis pain, any trauma pain, when you touch, you will get that pain again. So you can reproduce that pain. Other is your herpes zoster. That is usually prolonged kind of pain until disease persists. It is sharp and burning kind of pain. It has a having a dermatomal distribution. It is unilateral and restricted to a particular dermatome of chest. Vesicular kind of rash in area of discomfort will be there. And last but not least is psychology, in which comes emotional and psychiatric conditions. These pain are variable. They often manifest as tightness and dyspnea with feeling of panic or doom. Okay. They are also variable and retrosternal. Situational factors may precipitate these symptoms. Suppose you are having exam next day, your anxiety pain will appear. So, and history of panic attacks and depression will be there. Okay. Now, after seeing all the causes, cardiopulmonary, non-cardiopulmonary, and most important cause of cardiopulmonary is MI, and in non-cardiopulmonary is your GI. Now we will see how to approach the chest patient in emergency. Okay. So whenever you're approaching any kind of patient with any kind of symptoms, three things should always come in your mind. First is history taking. Okay. Second is physical examination. And third thing, investigations. So three things. First is history, then come physical examination, and then come investigation part. On history, first we will see quality of chest pain. What we'll see in history? First, history, quality of chest pain. You mean by quality? If pain is pressure, tightening, and squeezing, which we have earlier studied, it produces like a MI kind of pain. So pressure, tightness, squeezing, they are like MI kind. If there is a tearing kind of pain, a knife-like kind of pain. So I have previously told you, na, if there is a tearing or someone has stabbed you with knife, what is this? This is your acute aortic dissection, my friends. Okay. Third is pleuritic type of pain, which you find in any respiratory illness or any pleuritis. And in heart, which condition you get pleuritic type of pain? That is your pericarditis. Okay. Last but not the least is your burning kind of pain that you get in your GI condition like GERD or peptic ulcer disease. Okay. After quality of chest pain, we will come to the location part. Now, if pain is substernal, okay, radiating to arms, and most common arm which radiate and which lead to which has the highest chance of MI, that is your left arm. No, it is right arm, because in subsequent trial it has been seen that right arm pain carries the most likelihood, not left arm. So substernal pain and radiation to arm is most likely be your MI kind of pain. Other is any severe pain radiating to back between shoulders. What is this? This is acute aortic dissection, or you can say acute aortic syndrome. Okay. Now, there's a pain which radiates to trapezius. Which is that pain which radiates to trapezius? That is your pericarditis. Okay. After completing quality and location, we will come to pattern of pain. Now, what do you mean by pattern? Like fever has a pattern. It some fever which increase at night, some at day, some persist for the day. Pain has also pattern. Some pain comes with activity and relieved with the rest. But some pain starts suddenly and then they are constant. So there is a pain which comes with activity, okay, and goes with rest. What is this? This is your MI pain. Okay. Now, this is a pain which suddenly peaks, which suddenly peaks, and then it remains constant. What are these conditions? These are your aortic dissection. This is your pulmonary embolism. Okay. And last but not the least, it's like pneumothorax. Okay. So after completing quality, location, and pattern, we will come to fourth. That is your provoking and elevating factors. Now, suppose there is a pain which increase on activity and goes on rest. Which is this pain which goes on increase on activity and goes on rest? This is your MI. Okay. Second is a pain which increases on muscular movement. Which is this pain? Any musculoskeletal abnormality. Any musculoskeletal abnormality. Okay. Now, this is a pain which increase on supine and decrease on sitting. Which is this pain? This is your pericarditis and GERD. Because when you are supine, acid will go above. But when you're sitting, acid will be in stomach only. Now, this is the pain which increase on eating. Because when you eat, your stomach will produce acid and already peptic ulcer are present, so it will irritate it. So which pain is that? Which increase on eating? That is your peptic ulcer disease. Okay. Now, this is a pain which decreases on giving NTG. What is this? This is your stable angina or myocardial ischemia. Okay. After this, we will come to next heading, that is your associated symptoms. Now, what is in associated symptoms? Like we have said that there is something known as angina equivalents. What are these? These are your dyspnea. This is your nausea. This is fatigue. So, if you are getting dyspnea, nausea, and fatigue kind of thing, this is your MI. Okay. Now, suppose you are getting sudden onset of dyspnea. Sudden onset of dyspnea. In which condition you will get sudden onset of dyspnea? These are your pulmonary embolism, pneumothorax. Okay. Now, we come to syncope part, in which you can get syncope. So, syncope can be there in your when there is a massive pulmonary embolism. When there is a massive pulmonary embolism, or whenever there is a aortic dissection. Okay. Other is hemoptysis. So in all what condition you can get hemoptysis, you can get in your pulmonary embolism. Another is in your pulmonary edema. Okay. Other symptoms are nausea plus vomiting. Nausea plus vomiting in GI disease. And nausea plus vomiting is very much specific when it comes to MI is your inferior wall MI. So if you are suspecting any MI, there is nausea, vomiting, hiccups are there, so you have to suspect that is your inferior wall MI. And last but not the least, that is most important, that you have to take patient past medical history. Okay. Now, after completing our history, so four parts in history. One is your quality of chest pain, then comes location, then comes pattern of pain, then comes any provoking and elevating factors, and then came any associated symptom and past medical history. After doing history, and you comes to 2 or 3 details, then comes the importance of your physical examination. So, physical examination. In physical examination, first heading will be your general physical examination. So, what we will see in general physical examination? If is patient anxious or not, is patient uncomfortable, is patient pale, or is patient cyanotic, or is patient coming with the Levine sign, or patient body habitus. So if patient is anxious, okay, if he is uncomfortable, if patient is pale, or if patient is cyanotic, or patient is having a Levine sign, this all means that there are high chances of MI. Okay. Other thing you can see that is body habitus, like patient of Marfan syndrome. And you all know Marfan syndrome suspected to, it can be pneumothorax. Okay. After general physical examination, the most important thing that is your vitals. So in vitals, what are things? First, if patient presented to you with increase in heart rate and decrease in BP, what does it mean? It means patient is in shock. And if patient is in with chest pain and patient is having shock, it is cardiogenic shock. And cardiogenic shock, which all things can lead to cardiogenic shock, this is your MI, this is your pulmonary embolism. And also in pneumothorax, you can get systemic shock, or sorry, systemic collapse of all the organs. So pneumothorax. After that, if patient comes you with increased BP or hypertension, and I have already told you that hypertension is a risk factor for aortic dissection. So it can mimic early stages of aortic dissection. Okay. Now here is a patient which comes to you with sinus tachycardia, sinus tachy on ECG, or increased heart rate. So what will you suspect if there is increased heart rate, sinus tachy? Pulmonary embolism. Okay. Now patient comes to you, patient is very tachypneic. There is increase in respiratory rate and your SpO2 is falling. And when you order ABG, there is a type 1 type of respiratory failure. What does it mean? It means there is some respiratory cause. Okay. So after doing general examination and vital examination, we will come to examination of each system. So first system is your pulmonary system. So in pulmonary system, what you will first If patient is having pneumonia, so you all know that in pneumonia, if this is your lung, so if this is your lung, so this part, suppose this is the area of consolidation in pneumonia. So when you auscultate on this area, what you will get? You will get a bronchial sounds. And this area behave like a solid organ because lung is like gaseous, but now this consolidation part is behaving like a solid organ. So you will get increase in TVF, that is your tactile vocal pharyngitis. Okay. Next is your pneumothorax. Now, what is happening in pneumothorax? Suppose this is your lung. Okay. Now, suppose tension pneumothorax is there. So air comes in between two pleura. So now the pleura, this is now pleura. Okay. And this whole is now lung. And this in this area, air is there. Okay. Air. So what will you do? When you oscillate in this area, there will be a decreased breath sounds. Okay. Other is bilateral creps. So where will get bilateral creps? Suppose this is our your lungs. Okay. And patient is of CHF. Due to MI, patient land into left ventricular failure. Due to left ventricular failure, what is happening? Left ventricle isn't able to drain in its blood in aorta. So if left ventricle can't drain its blood to aorta, can pulmonary vein drain into LA or LV? No. So there will be back pressure. So this pulmonary vein blood will go back to pulmonary capillaries, and in pulmonary capillaries, what will happen? Leakage of blood will happen, and this will accumulate starting in lungs, especially in your basal parts. And when you auscultate in these areas, what you will get? You will get bilateral rails or creps. So in what setting you will get this? You will get in CHF, that is due to MI. Okay. Now comes your cardiac part examination. So in cardiac examination, what all thing will you observe? So first is JVP. So there will be increase in JVP because in congestive heart failure patient, this is your RA, LA, RV, and LV, and this is your SVC. As heart is failing, RV can't give blood to LA. Sorry, RV can't give blood to your pulmonary artery. Your LV can't drain, so pressure will come on to your right atrium and left atrium. The superior vena cava will not able to drain your blood in RA. So what you will get? You will get increased JVP. Second, you can get S3 and S4. That is your gallop rhythm, like a horse, because S1, S2, S3, and S4 that you get in failure patient. So it is like a gallop. Now you can also get your MR murmur and VSD murmur. So what are the reasons behind your MR murmur and VSD murmur? It is due to mechanical complication of MR. So you can get acute MR on VSD murmur due to mechanical complication of MI. Okay. Other is your AR murmur. So what are the reasons behind your AR murmur? Proximal aortic dissection. Okay. So you can get MR murmur and VSD murmur, then you suspect any mechanical complication due to MI. If you are getting AR kind of murmur, then you will suspect proximal aortic dissection. Also, you can get a pericardial rub, which you see in pericarditis kind of picture. Okay, so this your cardiac examination part is complete. After cardiac examination, we will come to your GI examination. So what you can get in GI examination? In CHF or in a right heart failure patient, you suppose this is your RA and this is your RV. Now, this is your SVC and this is your IVC. Now, heart has failed. RV can't give its blood to pulmonary artery. So, there is blood accumulating in RV. Due to blood accumulating in RV, RA can't give blood to RV. So, there will be back pressure in SVC. And due to back pressure in SVC, what are you getting? You are getting increasing JVP. This will also put back pressure on IVC. And what IVC is taking? IVC is taking whole blood from GIT and especially from your liver. So, this blood will accumulate in liver and can lead to a tender hepatomegaly. Okay, so you can get tender hepatomegaly. Now we will come to investigations part. So we have finished with history, physical examination, investigation. Now suppose there is your MI patient. You have taken history of that MI patient. So patient will be having tightening, burning, and squeezing kind of pain. Pain will be relieving on rest and increasing on activity. Then you do physical examination. On physical examination, suppose due to MI, patient is presenting with cardiac heart failure or CHF. So what you will get on examination? You will get signs of bilateral craps. What you will get? You will get increase in heart rate, decrease in BP. After that, what you will order? You will order investigation. And which is the most important investigation you have to order? That is your ECG. And ECG within 10 minutes of presentation. So any patient coming to you with in emergency, you have to get ECG done within the 10 minutes of presentation. So what you will get in ECG? In ECG, we will get change in ST segment. Okay. And what kind of change? Either it can be upgoing ST segment or downgoing ST segment. So there is a criteria to define upgoing ST segment or downgoing ST segment. You can't say any ST segment that is, if suppose there is an ST segment, there is increase in ST segment, but you can't say that is STMI. There is a criteria. If that criteria fulfills, then you will call that this is ST elevation and likely ST elevation or due to MI. So what is this criteria? That is new ST segment elevation at the J point. Okay. And that also in two contiguous leads. Suppose V1, V2, V3 you are getting in lead 2, 3 A wave, or you are getting in lead 1, 1 and AVL. Okay. So new ST segment elevation that also at J point in two contiguous leads should be there. And that elevation should be of around the elevation should be of 1 mm in all leads other than V2 and V3. Other than in V2 and V3. For V2 and V3, there is other criteria. What criteria is for V2 and V3? So you are getting in men's 2 mm criteria is there if patient is greater than 40 years and less than 40 years patient 2.5 mm criteria. So in V2 and V3, if patient is above 40 years, then there should be increase of 2 mm. Okay. And if patient is less than 40 years, then it should be greater than increase of 2.5 mm in V2 and V3 years. And if there is any woman, in woman greater than 1.5 mm, regardless of her age, is your ST elevation. So again, we will repeat. What is ST elevation MI? It is greater than 1 mm in any two contiguous leads except V2 and V3. For V2 and V3, if in men, if age is greater than 40 years, then 2 mm is significant. And if in men which are less than 40 years, 2.5 mm is significant. And in women, greater than 1.5 mm is significant regardless of our age. Now we'll come to non-ST elevation MM. In that, there should be a downslope of horizontal ST segment depression should be there, and that is should be of 0.5 mm in contiguous leaves. Okay, around 0.5 mm. So to see ST segment, we first must know what is the J point. So we will see what is the J point. So J point is the end of QRS complex. So here your QRS complex is ending, and this end point is your J point. And after that J point, ST segments begin. And then there is T wave. So for ST elevation, ST depression, we have to see this J point. So J point we have to see for ST segment elevation or ST segment depression. Okay. Now when we are seeing J point, there should be any isoelectric line we should know. So this is your P, this is your T wave. And between T and this P wave, there is your TP segment. And this TP segment is your isoelectric line in ECG. So we will mark our isoelectric line segment with TP, and then we will see with comparing with TP segment that your J point is increasing or decreasing. Like in this ECG, this is your P wave. Okay, this is your QRS complex. Okay, this is your T wave, and this is your P wave. So your TP wave is isoelectric, but QRS complex ending here. So J point is above that isoelectric line, that is your TP segment, and it is above three small box roughly around 3 mm. So it is ST elevation MI. That is your STMI. So you have to see J point. For J point, you must know what is your isoelectric line. The isoelectric line is your TP segment. You compare that point with TP. If that point is right, then you will say it is ST elevation MI. So here four small boxes which equal 4 mm, so ST elevation. Here you see other again figure. So this is your T wave. This is your P wave. This is your TP segment. So this is your isoelectric line. And from TP segment, when you will draw a horizontal line, what you will find that your J point has come below. So this is your ST depression. Now, in ECG, if it is MI, you will find ST elevation. Now, if in ECG, it is you are suspecting pulmonary embolism, what you will find? You will find sinus tachy and S1 Q3 T3 pattern. And this is your S1 Q3 pattern. What do you mean by S1? S1 means deep S wave in lead S1. Q3 means pathological Q waves in lead 3. And T3 means inversion of T wave in lead 3. So here you are seeing deep S wave in lead S1, Q waves in lead 3, and inverted T waves in your lead 3. This is your S1 Q3 T3 pattern, which is classical of your pulmonary embolism. Now, after ECG, we will come to chest X-ray. So, chest X-ray in pulmonary edema, which is due to MI, what you will get? You will get a CHF-like picture. Okay, which will get a curly B lines. Second is your pneumothorax. In pneumothorax, there is a jet black area. A jet black area with absence of vascular markings. Okay, see, this is your pneumothorax. Here you can see this jet black area, and this is your lung. This is your lung, and this is the jet black area you are getting. Whole jet black area. This is a whole jet black area you are getting. What is in the jet black area? This is air, the air trap. So this will get a jet black area in pneumothorax. Other things you can get consolidation and consolidation in pneumonia kind of patient. Okay, what you will get in consolidation? Suppose we take this lung. So here you will get a consolidation kind of picture, a white patch, okay, or opacity or opaqueness. You will find in pneumonia kind of patient. After that comes your cardiac biomarkers, which are your TROP-T and TROP-I. Okay. After cardiac biomarkers, what you will get? You can order other investigations like BNP, natriuretic peptide for heart failure patient, or anti-pro-BNP you can send. You can also send D-dimer for pulmonary embolism. Okay. You can also do treadmill test or exercise ECG test. Okay. And after that, your last is your non-invasive test. In non-invasive test, you can do echo, you can do CT angio, and you can do MRI. And what you will get in echo, you will get RWMA, regional wall motion abnormality. So see, this is the echo of a patient. Here you can see this is your left atrium, this is your right atrium, this is your left ventricle, and this is your right ventricle. So we are creating window from above, from chest. We are creating window. Okay. And which is the most anterior structure on heart is your LV and RV you find anterior, and LA you find posterior. So we are making a window with RV and LV. In LV, you can see that this is the area which is not contracting properly or motion is not proper. So this is your RWMA, which you get in your MI patient. Okay. So with all of this test, we here we end our session on chest discomfort. Okay. Thank you. I hope you have understood this lecture. Like and share and subscribe this channel. Thank you.